is looking towards right shoulder. People often call that anterior tilt or posterior tilt. What I always say is where the footprint is looking towards. If this is my abdomen, my footprint starts looking toward my right shoulder. That's what my tilt is. So what I've done, I'm going to go to perpendicular again. And now my footprint start looking towards my right shoulder. Look, the structure which was, let's trace this structure one by one, arrow. I'm tracing it back. Now my footprint is looking towards my right shoulder. Look, where does it drain? That is the most important part of a morphological array. And you could see hepatic veins draining into it. And Dr. Neeraj, Dr. Munish is already over here. I always say these words, God has never drained IVC to LA till date. We are still waiting for the God to do this. God has done to TAPVC, but the God has not done to RA to IVC. So we can be very sure that the structure where IVC drains is a morphological RA. And that gives a lot of strength, and we can see where is my, in this case, where is my eustachian valve is. If it's there, I can't see to a large extent. Again. And once I see this, my image is what you have been very fond of looking the image. This is what I say the image is on left hand side. Can I have my slides together again? Slide में convert कर दो जरा. Have slides. Okay. So this is where I started with, and this is where I moved on to my morphological array. And finally, these are the three structures: short axis, perpendicular, morphological array, and the structure on the other side is morphological LA. But we have to identify that morphological LA by two important things. One is the pulmonic venous drainage, which could be variable. Second, LA appendage. So we are going to identify that LA appendage in a couple of minutes. Before that, this is what image I showed you in a couple of minutes back. So this is anterior, this is right, this is left, and this is posterior. And this LV points toward left hand side. How does it point toward left hand side is? This is what I always say that if I take a piece of paper, look at my language. During normal embryogenesis, the state heart fold, this is state heart folds, to the right, this folds to the right, comes and occupy of left side of a chest. This is how folds to the right, comes and occupy the left side of the chest, so that the right ventricle is developed anterior and to the right of left ventricle. Very simple way of looking at it. Folds to the right, comes and occupies to the rest of the chest. And what does this transform to? This transforms to a very simple looking at this particular image. Look, this is LA, this is LV, this is RA, this is RV. If I go back, what I said a couple of minutes back was RV anterior and right to the left ventricle. RV anterior and right of the left ventricle. and this is what is known as D loop. Now so many combinations can be available apart from this. We talk of situs inversus, situs ambiguous, D loop, L loop. So many of those combinations can be possible by just looking at these basic pictures. Let's see, folds to the right and comes and occupies to the left side of a chest, right side of the chest. What does will happen? LV, LA, there will be anterior and right of the RVR. Right in the center itself. So the first picture, if you are doing a pediatric echocardiography, is you identify this is how it opens up, your views. Because this is the most important thing to begin with for them. Otherwise, I've seen many people when they talk of a situs solitus, D loop, L loop, they make many of the mistakes right from the beginning itself. Neeraj?
So, what we have been seeing is if you can identify situs and looping, most of the things are sorted out by here on. Suppose you sort of situs, solitus and looping and extracardiac position. Most of things will come into picture gradually. And if your situs ambiguous structures, sometimes in those cases IVC may drain into it. If you have situs ambiguous situations, then IVC and HVC can drain ambiguously. That is the only situation when this rule of IVC draining into RA will not apply.
Like in that situation, it is not true LA or RA. That's why that ambiguity word is there. So when we are talking about this, situs is very clear. We know this is situs solitus, this is situs inversus, and ambiguous or heterozygous. Actually, in true sense, there is nothing ambiguous. We need to know what it is. It is either left isomerism or right isomerism. Okay, so that we will discuss in later presentations. So whatever type of situs it is, when it is isomerism, means left isomerism means both atria are left-sided. When it is right isomerism, both are right-sided. And then that mixture happens. Systemic veins, bilateral SVC2, ipsilateral atrium, IVC in the floor of atrium, hepatic veins are joining separately, pulmonary veins, do idhar hai, or they all are forming a confluence or joining somewhere. So that mixture happens when our atria are confused. So otherwise, with situs solitus or situs inversus, as I said, IVC, suprahepatic part of IVC, that is very clear. Suprahepatic part of IVC, Eustachian valve join right atrium, and the most consistent feature for morphology to define atrium is appendage. Appendage, sometimes it is difficult, especially in grown up. In pediatric, we are very comfortably able to define this is right, this is broad base atrium, packed prominent ducted muscle, while it's on the left side, it is the typical structure. So it is, we are very clear for pediatric point of view, but adult because of images issue. Flap, suprahepatic part of IVC, Eustachian valve define our left and right sided atriums. And that, like sir is saying, left LV. So why it is LV, that we'll discuss. Why it is RV, that we'll discuss. Why it is aorta, we'll discuss. Why it is pulmonary artery, not the RPA from ascending aorta. So there are many combinations in the congenital heart defects. Each segment, we have to stop at each segment and then proceed. So that systematic sequential approach is very important to, just to, one very interesting case I saw yesterday only. I'm having his X-ray and CT only. So it was situs inversus, abdominal, okay? Liver, stomach was on right side, liver on left side. Typical situs inversus. Bronchus, because CT was there, it was inverted. So abdominal and respiratory situs inversus, but atrial level it was situs solitus. Typical LA on left side, RA on right side. Okay, so that discordance also happen. So situs inversus doesn't always mean the atria will be inverted. So that is the importance of each segment is so important in congenital cardiac approach. So it was so like now you need to take time. I was dealing situs inversus, suddenly LA is there, RA is there, systemic veins are on RA, pulmonary veins on left atrium, very typical. Appendage and everything was fitting into situs solitus for atrium. But abdominal and bronchus, situs inversus. Then when I moved to ventricle, there was reverse offsetting. Okay, so you think it is corrected TGA? So my left-sided valve, AV valve was at lower level, right was higher. So reverse offsetting clearly, but left-sided ventricle was smooth, right was trabeculated, mortated band was on right side. Okay, so you can imagine any combination you can have. If you look at the offsetting, it is very typical of corrected TJ type, means L-loop ventricle, but it was not, it was a D-loop ventricle. Because morphologically it was LV, it was right ventricle. Normally we say AV valve goes with the ventricle, it was going with the ventricle, it was typical of mitral valve, papillary muscle, single papillary muscle to the free wall of the left ventricle, but offsetting was reverse. Okay, so everything, you can't skip a single segment when you are dealing with the congenital heart defects. This is a very beautiful thing actually, and when you get involved into it, you just see so many things into these hearts. It's just, I saw yesterday only, that's why I mentioned this case.
So I'll move further now. I'll explain on the machine itself because that'll be the more important thing. So going from this particular point, Hubbard's machine. Some problem, Hubbard's? Okay. Now I'm sliding from this particular image to what we talk about morphological RA, other structure is morphological LA. So what I normally do is, it could be, घूम जाओ बेटा, हल्का सा उधर घूमो. We slide to apical window. हाथ ऊपर कर लो हल्का सा. So this was on right side was morphological RA, other side is a morphological LA, and I have to identify now the most important thing is left atrial appendage, and that's how I'll try to open my left atrial appendage. Dr. Neeraj, can you show the left atrial appendage? Yeah, it's a left atrial appendage which you see over here, and then we identify the various veins which are draining into this left atrium. And the best part of looking at these various veins is to look for a color flow. Reduce the Nyquist limit to almost 30 to 40. Now you can see a drainage of all pulmonic vein right side as well as on the left hand side on this side coming from the left hand side. We have to identify all these pulmonic 4 veins. That's the most important thing in pediatric echo. Then moving from this pulmonic veins, another important point at this pulmonic vein is we put a caliper and try to measure the velocity of these pulmonic veins. Pulse wave, simple volume, we have to right into the pulmonic veins.
It's internally picking up the aorta.
Yeah, it's picking up aorta.
Elevating the internally goes into the slightly bigger child.
Actually, smaller child will weak. It will not let a demonstration being done.
They will not allow anything.
Now you can see a pulmonic veins very category. And that's at least I always like to have ECG gating so that I can understand what is S wave, what is D wave when I'm talking about pulmonics. And I will always look for all 4 pulmonic veins so that at this particular point I'm comfortable that my pulmonic venous drainage is comfortable. Second thing, number of time I have noticed the pulmonic venous flow velocity is almost up to 30 to 40 centimeters per second. Sometimes it's very high, close to a 1 meter per second. That is what pulmonic venous obstruction leading to elevated RVRA pressures. So here itself we'll know that something wrong is happening with the child itself. Second important point which I have noticed number of times, whenever there is a shunt, I'll find a lot of blood which is flowing into the pulmonic veins. So many other things just you observe and starts telling you right in the beginning, look, something wrong is happening with this child. And it's not that it's only a pulmonic venous flow which has happened, a shunt is present. Even the patient who has got a significant lung infection, even the pulmonic flow we have seen number of times on a higher side. So just be cautious what exactly we are looking and dealing with. Second important point is this is now once we look at this particular phenomena, I look for a kind of a valve. So I'll freeze over here the kind of a valve I'm dealing with. Now this is very important, all of us you know about it. One is a tricuspid valve, one is a mitral valve. Tricuspid valve is always apically placed. Hinge point of a tricuspid valve is apically as compared to mitral valve which is basally placed. And it is said the distance between these two hinge points should be less than 8 millimeter per meter body surface area. It has to be millimeter per body surface area. And that is the differentiation when we talk of Abstein anomaly. When my distance is more than 8 millimeters per meter body surface area, we start talking of Abstein anomaly. So this is one how we start looking at their mitral and tricuspid valve because of their hinge points. Next comes RV and RA, RV and LV. Look, LV is always a clean shaven structure.
I have a question about the pulmonary veins. May I?
Yeah, go ahead.
If you names nomenclature, the upper and lower, in the 4 chamber view, can we see all the 4 veins or 3 veins?
Neeraj, show them upside down now. Because Dr. Sahana, she is working in NICVD at Dhaka.
You are right, actually.
She is assistant professor right over there.
Yes, 4th vein, left upper is difficult to see in this view. So you go to the short axis view. So left upper you want to see, you have to go to the short axis, parasternal short axis view.
Left upper pulmonary vein is important for us, for even in the diastolic dysfunction. For that reason, I'm asking. If we can see the typical 5 chamber view.
I think if you want to see left upper,
Yeah.
best view it would be left short axis. Let us try to see the.
बेटा थोड़ा सा ऊपर कर लो. हर्बल रीना एक मिनट आप आ जाओ, थोड़ा सा हेल्प कर दोगे? हाँ थोड़ा सा ऊपर करेंगे प्रेशर. बस बेटा, गुड ब्लेस यू, थैंक यू बेटा. वाओ वेरी गुड. अब तो बड़े हो गए साइमा जी. आप
Start from the right side of veins. The cursor. And the track ball कहाँ है आपका? ये the track ball? हाँ, okay. So this would be the. Yeah, you can see the track ball here. Yeah. So I am seeing the right side vein here. All of you can see the right upper here.
Yes.
I will go to 2D also if I see. Smaller children you can see better. windows, but here also you are able to see this. So I put the color and that's the right side vein. Now the vein which you are seeing on the left side, this should be left lower vein. Okay? Are you able to see this? Now I will go to the short axis view and try to see the other vein. Congenital people will all go with the short axis view to profile veins better. Now this vein, okay. So track ball again. So this should be left lower vein, left lower pulmonary vein. Somewhere here I would get the right upper vein, and then I am trying to focus on the left upper. If I can show left upper, somewhere here the blue color would come like a left upper. Slightly bigger child. Dress बेटा आपको dress में थोड़ा ऊपर करना है, थोड़ा और ऊपर जाना है. Sometimes you have to go high parastomach. So she has a tight clothes. Yeah, okay. So I think we will show you some other smaller case, better windows, but you can see the left lower vein here, and can you see the right side vein here? Yeah, this is the right side vein. Again, right upper, right lower, and I'm seeing the flow of the left upper pulmonary vein, but not very clearly. But this is the left upper pulmonary vein in between. Then one more view is crab view. If I can show the crab view, सीधा हो जाएगा एक बार. Suprasternal crab view. Pointer towards 2 o'clock or 1 o'clock. So this is the crab view. 2D gain. Reduce the 2D gain and start seeing the left lower. So this is the left lower vein, left upper and right side vein. So in a smaller child, this view, crab view, will be very good. In a bigger child, this may be difficult. But you can still see left side vein very good in the crab view.
Is that okay, Sanu?
And I will further go into the details when we have smaller kids.
So that's how we look at pulmonic veins. We'll look at the mitral and tricuspid valve, and then next comes look at the ventricular morphology. Can I come on? Thank you.
Sorry.